Thank you so much, Gurjit, and for organising us all, and a huge welcome to everyone who's joined us for the final Catalyst seminar for this academic year. I'm Liz Pellicano, and I'm Professor of Autism Research in Psychology and Language Sciences at UCL, and I'm absolutely delighted to be able to chair this seminar on neurodiversity and mental health. There are so many injustices that neurodivergent children and young people face, which can create real challenges to their mental health. So this topic is enormously important, and we're very grateful once again for you for making the time to be here today, especially given that we're competing with a gorgeous sunny day. But we've got a fabulous lineup of speakers to make it all worth it. We have Mandy, Jeanne Wolstencroft, and Jack Welch, each of whom are going to speak for about 15 to 20 minutes. And that will leave us with a good 15 minutes or so for questions at the end. Because we're only taking questions at the end, I encourage you to write your questions in the chat and even have a discussion in the chat. That would be brilliant. And if you could all remember to mute yourselves before we start too, that would be amazing. Right, so without further ado, I'd like to introduce Professor Mandy. Will is a clinical psychologist and professor at UCL, where he's also deputy head of the Department of Clinical, Educational and Health Psychology. His work is aims to improve the recognition of autistic children, young people and adults, particularly in girls and women. And he also is a huge advocate of designing, developing, implementing interventions and supports to really help autistic young people make those important life transitions, and to also teach young people about their autism diagnosis with a real emphasis on fostering their sense of self-worth and pride. So I'll hand over to you now, Will. Thank you.
Thanks so much, Liz, for that introduction, and thanks very much to the organisers of these wonderful Catalyst seminars for inviting us along today and for kind of focusing on this topic, which I obviously think is a really important one. So I'm going to be sort of perhaps providing a bit of context, a bit of background, as well as talking very briefly about some findings from a study that we're currently writing up in the Millennium Cohort study. And one of the things I'm going to be looking to do is to kind of talk about, expound upon, give my sense of what a neurodiversity perspective on autistic mental health might look like in practice. So I'm going to start off by talking about what I've previously called the autism mental health crisis, which is obviously quite a dramatic term, but I personally think is a justified one, actually, for reasons I'll explain. I'm then going to talk about this sort of collection of ideas that's come to be known as the neurodiversity paradigm, which is currently kind of hopefully helping to kind of reorganize autism research and practice and the way that people think about the experiences of autistic people. And then I'm going to give an example of a kind of initial attempt by myself and some colleagues to kind of operationalize, if you like, the ideas of this neurodiversity way of thinking about autistic experience into an actual concrete qualitative study, which is about trying to understand one potential influence on the mental health of autistic young people. So the autism mental health crisis. So, I mean, I think it's always worth starting from this point, of course, making the point autism is not a mental health problem, but autistic people are, under our current sort of systems and kind of situation, at very high risk of developing mental health problems. And that was certainly a finding that really, I think, for someone like myself, for a non-autistic researcher, really came to prominence in my mind with this paper here by Emily Simonoff, Gilly Baird and others, where they looked in a community ascertained sample of autistic young people. So these were not autistic people who were necessarily presenting at a clinic or seeking help. And they assessed their mental health, and they found that 70% of them met criteria for one DSM-4 mental health condition, and 41% had two or more mental health diagnoses. So, really striking findings and indicative of a really high level of need in this population. And that's a finding, this idea that autistic people are currently at much higher risk than non-autistic people of developing mental health difficulties, has been shown time and time again. And if you're interested in this large meta-analysis led by Meng-Xuan Lai and Caroline Cassie is a really good place to start, which demonstrates that fundamental fact about the lives of autistic people, in our current culture, in terms of that high risk of a really wide range of mental health challenges. As with non-autistic people, the evidence would suggest that the mental health challenges of autistic people are usually established before the transition to adulthood. They at least have their genesis there. It perhaps almost goes without saying to say that they reduce quality of life and functioning, and also they would appear to make quite a major contribution to the unfortunate fact that autistic people experience higher mortality currently than do non-autistic people, with a key mechanism here being the relationship between, on the one hand, mental health problems, and on the other, the elevated rates of suicidality and of suicide amongst autistic people. So clearly the picture I'm painting there is of a really high level of need. Something has to be done here, and yet I think it's pretty safe to say that, and I'm not wishing to criticize individual services and certainly not individual clinicians, but I think, looking at the piece as a whole, mental health services for autistic people are just currently not fit for purpose. They're not able to come anywhere close to meeting that need that I've outlined. And we see that from various surveys of the experiences of autistic people, in the time after they've been diagnosed, for example. And there are various other indicators of, low satisfaction, high rates of polypharmacy amongst autistic people, and, autistic people, certainly in the UK, being overrepresented in mental health crisis care settings, with the implication that their difficulties have, if you like, been allowed to get to this point of requiring this really, high level of acute care, with the implication that things earlier in the pipeline, have not been effective. So there's an awareness that things have to change. This exercise, this priority setting exercise, was run by the James Lind Alliance in partnership with the Autistica, which is a really well-known autism research charity and sort of campaigning organization. And they consulted with 1,000 members of the autism community, and the very top priority that came out of that from the autism community for what autism research should be focusing on is this one here: which interventions improve mental health or reduce mental health problems of autistic people, and also this sort of subsidiary question of how current interventions can be made more accessible for autistic people. And we also find, the World Health Organization and the NHS really acknowledging the fact that this is a moment where we really have to build and improve the kind of care that is available to autistic people, and I suppose also, to restructure things with a preventative goal, so that, of course, so that the problems are much less likely to develop in the first place. So that's kind of what I meant by the autism mental health crisis, that, really autistic people have a high chance of developing mental health challenges, but a low chance of receiving effective help for these currently. So I think that one promising way in which we can move the situation forward is clearly we need to build a better evidence base. We need a better understanding of why autistic people experience this high risk of developing mental health challenges, so that we can be better in our efforts at prevention and in helping with those mental health challenges. And I think this neurodiversity paradigm I'm about to talk about is potentially a really powerful way of thinking that can help us in that task. So what do I mean by this neurodiversity paradigm? Well, let me talk about what I consider to be its fundamental feature in relation to mental health. So, people have been, researchers, clinicians, and, more and more recently, autistic people have been involved in this effort to try and understand better why is it that autistic people experience a high risk of mental health difficulties under the current situation. And I think it's pretty fair to say that for most of the history of autism research, and indeed much of the research that's being done today, tends to come up with an answer that sort of runs along these lines, right? Which is that, if the question is why might autistic people experience high risk for a mental health problem, the old model, or sometimes called the pathology model, tends to look at the autistic individual for the answer and to try and draw a straight line between, on the one hand, the characteristics of autistic people, and on the other hand, their elevated risk. And very often what that turns into is consideration of so-called impairments or deficits of autistic people, and trying to draw, if you like, a straight line between those and mental health difficulties, whether it be, oh, well, it's to do with sensory processing atypicalities or intolerance of uncertainty. That must be the explanation for this high risk. So what I would say is that is a really one-dimensional and kind of flat account of this issue. I think it represents an inadequate attempt to formulate, both in the sense that it doesn't map reality well, but also I would say there is a kind of moral problem with it, in that it very much situates the problem within the person. Whereas what we know, of course, is that all of us exist in environments. We exist in a context, we are shaped by that context, and of course we ourselves shape that context in a sort of ongoing dynamic process that unfolds over time, and which influences our risk and our resilience. And so what I see as the really key sort of commitment of the neurodiversity model is to view people in their context, to be interested in how the environment influences them as people, how they influence the environment. And often, I think it's a much more apt way to view, for example, risk, and indeed resilience, really not in the context of characteristics of the environment, not simply as characteristics of the individual, but by trying to formulate in some way the fit between the person and the environment. Now, you may be saying, well, this really, Will, is what you're giving us here is old wine in new bottles. This sounds quite familiar to those who are who know about the social model of disability, who studied kind of Mike Rutter and Dante Cicchetti's kind of version of developmental psychopathology. And I'd say fair enough. I think that is true. These are really, really good ideas. But I think the point is that there's currently a real commitment to apply these properly to understanding the experiences of autistic people. And that generally the field has been quite grounded in this old psychopathology model. So I think we're in a moment of change, and this is brilliantly summarized in this the sort of instant classic that our chair today wrote with Jackie Den Houting, which is kind of putting forward this thesis that autism is shifting from normal science, a sort of paradigm shift, which is why I've got this cube here, to neurodiversity in autism science. And Liz and Jackie kind of contrast the kind of three pillars of the old approach, which is it's disorder and deficit focused, it's highly individualized, it tends to locate problems in the people, and it tends to have limited consultation with autistic people. And the aim of this type of work has tended to be, even if it's not actually explicitly stated, of kind of quote unquote fixing autistic people, maybe making them less autistic or changing them in some way, in the hope that that will, for example, improve their mental health or their well-being. Whereas this new neurodiversity model tends to see autism and other forms of neurodivergence as difference, not as some sort of inherently disordered state. And that's very closely linked to there being a really strong influence and interest in context. And this model also has, as part of its essence, really, the centrality of autistic perspectives, and I suppose really crucially the goals of this type of work are different from the old model. It's not about fixing or quote unquote mending autistic people, it's about enhancing quality of life, thinking flexibly and creatively about what that would look like. So my view is that this is a set of really good, powerful ideas. But for me, I feel like the task is now, how do we translate them and actually kind of embody them in research designs. And I think on the one hand, in qualitative research, I think it's much more obvious how that works. I think in quantitative research, I think it's a bit less obvious. And I think there's some work to be done in terms of building up methods where we can kind of integrate quantitative methods and the neurodiversity paradigm. And so I've done a little bit of thinking about that for this talk and for this these very brief findings I'm going to tell you about. And so I'm kind of framing this task of applying the neurodiversity paradigm to quantitative research in autism. How do we learn more about the role of context and the environment in the development of mental health and mental health challenges of autistic people? And I think, and this is, relevant given the nature of this seminar, I think clearly a focus on childhood and adolescence. There's a lot to be said for it, with this idea that this is often the time when many of these difficulties have their genesis, have their roots. So that's the time to sort of, if you like, witness and try and unpick the emergence of difficulties. Clearly, we need to be interested in associations between environmental risk and protective factors and mental health outcomes. But I think crucially, we want to try and find designs to model the dynamic interplay between the environment and the individual by asking questions like, well, how does the environment affect the person? And how does the person affect their environment? That would be really, I think, wonderful if we could begin to get at as I said, this dynamic interplay. And to do that, clearly we need longitudinal data. We need to try and witness and measure processes as they play out over time. So I'm going to talk about one sort of initial attempt to do that. This was done in the Millennium Cohort Study, which is sometimes called the Child of the New Century. This is a population representative birth cohort based at UCL, Institute of Education. Initial sample was over 19,000 kids born at the turn of the millennium between September 2000, January 2002. And participants were assessed at multiple waves of data collection, including giving information on their mental health. And what's important for our purposes today is that us and other researchers too have identified a subgroup of young people in the Millennium Cohort Study who have, at some point before the age of 14, received a diagnosis of autism spectrum disorder, is the way it's asked in the Millennium Cohort. So this is a parent-reported diagnosis of autism spectrum disorder, and there are just shy of 600 such young people that we've identified in the Millennium Cohort Study, and it's with 560 of them that this next bit is kind of done. So what this is an attempt to try and better understand the interplay between what is effectively for young people a feature of their environment, which is the mental health of their main caregiving parent, and their internalizing symptoms or difficulties. And by internalizing, I'm talking about that sort of broad construct, dimensional construct, that really manifests in such clinical entities as anxiety, depression, somatization. So we're interested in the interplay between, on the one hand, parents' mental health, and on the other hand, young people's internalizing challenges. It's Dr. Maxi Shesk who did most of the work here as part of her DCLIN Sci thesis, and she was co-supervised by Dr. Rob Saunders, the excellent statistician, excellent and prolific statistician in our department who helps out in lots of our projects. So we investigated 560 young people in a Millennium Cohort Study who had been reported by their parents to be diagnosed as autistic at some point by the age of 14. With no subsequent evidence that diagnosis has been removed. Internalizing difficulties were measured using the Strengths and Difficulties Questionnaire, Emotion and Problem Subscale, at ages 3, 5, 7, 11, 14, and 17 years, so at multiple waves. And parental mental health, so the main caregiver, which was in most cases in this study, the great majority of cases was the mother's mental health, using the Kessler-6, this widely used and brief measure for this purpose. So again, administered at the same time points as the SDQ. And we used a type of structural equation model called a cross-lagged panel model to try and get a better sense of the interplay between parental mental health and internalizing autistic people over time. So this is a model that you can use when you have, in this instance, two variables. You're interested in their relationship with each other, and they're measured at several time points. So here we have x1, x2, x3. That's one of our variables. We've got y1, y2, y3 there, each measured at wave 1, wave 2, and wave 3. And what the model does is it accounts for, if you like, both models and controls for stability of these traits over time. So that's these pathways, for example, that go from x1 to x2 or x2 to x3 or y1 to y2. It models the association of the traits with each other cross-sectionally. But most interesting, really, from our point of view, it looks at so-called lagged associations. It asks, does your level of a trait, let's say at y1, does that then predict, controlling for all these other factors like the consistency of y over time and the cross-sectional relationship with x at the time, does it predict changes in the other trait, x2? And of course, it's reciprocal as well, so it goes the other way. You can also look at how the x1 trait predicts the y2 trait. And the idea being that this is a really tightly controlled design that moves you a little bit closer to kind of causal inference in trying to get at, is it that your changes in one trait, within-person changes in one trait, contribute to changes in the other trait? And you do that by looking at these cross-lagged panels. And that we used a particular type of cross-lagged panel model called a random intercept model, which is a particularly controlled model that really tries to hone in on within-person change at one time and whether that's associated with, predicts within-person change in your other variable. And very briefly, just to say what we found in relation to our question, what we found was that parental mental health at 3 years, and then there was a marginally significant finding at 5 years, was predictive of subsequent changes in child internalizing symptoms at the subsequent time point. So parental mental health at 3 years is associated with worsening internalizing symptoms in the young person at 5 years, and similarly, again, marginally significant, but there was a suggestive relationship that if you like, a decline in parental mental health that we observe at the age of 5 years predicts a decline in the young person's internalizing symptoms and their mental health at 7 years. Now, we also find something intriguing in adolescence. We find, and this is where I might talk about reciprocal relationships comes in, I think. What we find is that actually a worsening internalizing problems of autistic young people at the age of 14 is actually predictive of worsening parental mental health at 17. So there seems to be, there's an argument for if you like, the relationship going both ways at different ages. So in younger children, the relationship is particularly running from the environment, if you like, from the parents to the child, and converse in adolescence. So that's just an example of, I think, of some of the things you can begin to learn and unpick when we try and use longitudinal data to implement our interest in sort of person-environment interplay. So just to summarize, the neurodiversity paradigm is increasingly influential in autism practice and is a powerful way for increasing understanding of autistic young people's mental health. We need to develop ways to operationalize its principles and research designs. I think that will be an ongoing process. I would argue that this holds a lot of promise, I think, for trying to address the autism mental health crisis by actually building an evidence base that tries to get to grips with the ways in which contexts are shaping autistic people's mental health. So it will help us in terms of, in this example, formulating and treating internalizing problems for autistic young people by giving due consideration to the family system, supporting the family system and the parents around them, as well as perhaps working directly with the young person. So that's me done. So thank you very much for listening.
Thank you so much, Will. That was great. Yeah, a really good example of how to, take a neurodiversity approach in autism science, a more quantitative approach. We're gonna move on directly to the next talk. But if you've got questions, write them down now so they don't forget them, or pop them in the chat. And we'll come back to you later in the session. But now I am delighted to introduce Jeanne Wolstencroft, who's a research fellow at the Great Ormond Street Institute of Child Health at UCL. Jeanne is currently investigating changes in the mental health and behaviour of children with rare genetic disorders in the National Imagine ID study. So Imagine ID stands for Intellectual Disability and Mental Health, assessing the genomic impact on neurodevelopment. Really pleased that Jeanne could join us today, and I'll hand it over to you, Jeanne.
Thank you, Liz, and thank you, Will, for that brilliant conceptual introduction to kind of lead into what I'm going to talk about, which is work we've done on the Imagine study. The Imagine programme of research is a collaboration between psychologists, psychiatrists and geneticists interested in understanding the links between brain and behaviour in children and young people who've got either early developmental delay, learning difficulties or intellectual disability. And we were originally funded by the Medical Research Council and Medical Research Foundation to recruit a really large cohort of children between 2014 and 2019, and we've subsequently been refunded to follow these children up over time longitudinally. But today I'm only going to speak to some of the findings in Imagine 1, but just to acknowledge that it's been a huge effort which has involved far more people than just me today, and I've got the pleasure of presenting some of our findings relating to autism today on behalf of the Imagine consortia. So in order to talk about autism in the Imagine cohort, I'm first going to tell you a bit more about how exactly our families and children were ascertained, and then we're going to focus on these autistic children's mental health and then in turn their parents' mental health. So we've got a vast cohort of children and young people, and I'm going to speak today to the kids in our cohort are aged 4 to 19. So they were ascertained early for having a developmental delay, which is when at that point at which they were probably then referred on for genetic testing. Because of the costs of genetic testing has gone down, it means that clinics are using genetic tests far earlier to try and see if we can identify a genetic etiology to that developmental delay. And for that reason, we mainly have genetic results which are copy number variants or single nucleotide variants. The actual nature of the genetics doesn't really matter for the purposes of today's talk, but what's important is they're fairly small genetic changes, whether they're additions or deletions of genetic material or more complex chromosomal structural rearrangements. The reasons why we could be so ambitious about recruiting such a vast number of families to the Imagine study, so we recruited over 3,000 families, was because we have an NHS network of regional genetic centres across the UK, and all of these genetic centres were on board as part of our recruitment procedures and were identifying families for us locally who'd got a positive test and an identified genetic cause for their learning disability, and we're able to recruit them locally and send them to us and ask them whether they wanted to take part in a research study or not. The other crucial factor was that we took advantage of the fact that over 80% of adults have access to the internet at home, and that's a pretty old figure, so it's probably higher now. And so we were able to ask parents of children who had rare genetic conditions to fill out some rather quite lengthy questionnaires for us about their children online. And when I say lengthy, our families are really committed. They would spend upwards of 2 hours, I'd say on average about 3 hours, completing these online questionnaires for us. What were we asking them to fill out? We asked them to fill out a range of different questionnaires, but our key one was the DORBA, which is the Development and Wellbeing Assessment, which is a structured psychiatric interview, which is made up of lots of different modules. So it gives you a really comprehensive idea of what's happening in that child and young person's mental health and behaviour. And then all of those modules are reviewed and rated by a clinician and assigned DSM diagnoses. And the reason that we were particularly keen on using the DORBA was partly because it gave us this really, broad view of what was happening, and it meant we were able to think about diagnostic overshadowing. but also because it's the tool that they use in the English National Studies of Child and Adolescent Mental Health, which have run in 1999, 2004, 2017 and 2020. So we've got really good data that we can compare to as to what's happening on a national level with child and adolescent mental health. The Doorbell includes a few other tools like the SDQ, which is Will has already mentioned briefly, which is a brief behavioural screening questionnaire. Also includes a questionnaire where parents self-report on their own mental health called the Everyday Feelings Questionnaire. So it gives us an idea of how much psychological distress they're under. And then we have some other measures that I'm not going to speak to too much today in the battery of Imagine tests. We've got a picture on the left here of the screen of some of the reports that we send families. You know, we know as researchers that what we're doing is valuable, but it's very difficult for families to see the impact that that's having because the findings come out in a publication, especially in a large-scale study, years after they've initially taken part. So one of the things that we wanted to do really early on was make sure that families felt they were getting something out of taking part in our study, you know, every time they gave us data. And we've continued this approach longitudinally, and families receive a report on an annual basis when they complete questionnaires for us. So if you can do it, really helpful. We worked with our charity collaborators, Unique, the Rare Chromosome Disorder Charity, as well as some of the first families who have taken part in the study to develop these reports. And actually we found out through doing this that what parents found useful was kind of like a traffic light system summarising their child's relative strengths and difficulties to what you'd expect for neurotypical children. And we know that some really savvy parents have been able to use these reports to be able to advocate for their child's needs, which is great in terms of evidence for educational healthcare plans and such. So who are these kids? We've got a minimum data set on 2,397 children, and the sex split within that is fairly equal between the boys and the girls. And the average age of the cohort is young, it's 9 years old. And you can see from the age distribution chart on the right that actually half of those kids are under the age of, well, are 4 to 8, so under the age of 9. And that really is a reflection of how early kids are getting receiving their genetic diagnoses clinically when being seen by NHS services across the country. And if we ran the Imagine 1 study again now, those ages would be even younger. We are very proud that our sample is nationally representative of what you would expect in the UK, which is something that can only really happen, and you can only really get that sort of data on socioeconomic status and have it be representative of the context within which you're working if you operate in a context where healthcare is free at the point of delivery, which is a huge advantage of our cohort compared to lots of other large-scale phenotype or genotype first approaches that happen in other countries. So we have Dorbers on over 2,000 children, which were rated. And the main highlight from this really is the high levels of mental health and behavioural and neurodevelopmental conditions within the cohort. And I'm not going to speak too much to that because actually our focus today is the children within the cohort who we identified as meeting criteria for autism. And approximately a third of our cohort met criteria for autism. And the reason we're particularly interested in the autistic children in our cohort is because historically there's been a blurred line between autism and learning disability. Whilst initially it was thought that most autistic children had learning disability, nowadays most children who are diagnosed as autistic don't have a learning disability. So actually the tide has turned completely. And it's really rare these days to look at research happening in the field of autism and see that children who have learning disability have been included. Most of the time, the exclusion criteria is having a verbal IQ at least of 70. But it's really important that we still try and include these children in research, and that's not with, I fully understand all the challenges of working within learning disability, but it's still really important because they make up a substantial proportion still of autistic children, and their needs are going to be different from those who don't have learning difficulties, and we're not going to really understand how to address them if we consistently exclude them from research. So I'll speak first to kind of mental health in our autistic Imagine children and young people. We know that autistic children are more likely to meet criteria for additional psychiatric diagnoses and co-occurring conditions. And we know that children who have learning difficulties are also at increased risk of meeting criteria for these additional conditions. But what's the differential in risk if you have learning disability and autism versus just having the learning disability? And we wanted to have a look and see whether we could quantify the strength of that association. If we just look at the group comparisons between the groups, we see that there were substantially more co-occurring conditions in terms of anxiety and mental health, but also in terms of behavioural disorders and ADHD in our autistic children in Imagine compared to those who had ID or learning disability alone. We wanted to model that, and that's what we did. We did a series of hierarchical linear regressions to try and see whether that association was robust, and whether, when you took into account all of the other characteristics that that child might have, whether those associations remained. And what we found was that if you had autism on top of your learning difficulty, you were twice more likely to have an anxiety disorder, oppositional defiant disorder, or ADHD. So quite a substantial increase in difficulties, particularly in terms of the anxiety conditions and thinking about mental health. Now, if we turn to thinking about the mental health of the parents of these autistic children, what we wanted to find out was whether there were any differences in parental psychological distress in Imagine's autistic and non-autistic children. And also, if there was a difference, what are the behavioural symptoms within that child that are having an impact on parental psychological distress? Because in the learning disability literature, we know that it's not the degree of the intellectual or the adaptive impairment that's been associated with parental psychological distress. We know that it's the behavioural difficulties or the mental health difficulties. So what does that look like in our autistic children? And I suppose it's also worth noting that whilst we've modelled this in a way where we've looked at, how does the child's behaviour predict the degree of parental psychological reported distress, we acknowledge that there are going to be bidirectional relationships, and we've looked at this in a very static sense. And we've collected data in our longitudinal study in a way that we'll be able to start looking at those relationships in a more transactional way over time, using the sorts of models that Will's talked about earlier. So again, if we look at the group comparisons on our report of parental psychological distress, we're seeing that parents are reporting having more psychological distress if they've got an autistic child. And using the SDQ and thinking about different areas and domains of strength and difficulty, we're also seeing that the autistic children are being reported to have more difficulties with emotional symptoms, hyperactivity / inattention symptoms, and conduct problems. But again, how does this hold up in some models when we start looking at the other degree of complexity in this cohort and the other things going on for that child? Well, autism is still significantly associated with parental psychological distress when you start taking into account that complexity, as well as other confounds related to the family environment and the child's needs or characteristics. But what's interesting when you start looking at the beta coefficients for the different things that we've got on record, because obviously I'm acknowledging that we might have some other things that we need to account for that we've not recorded and therefore not been able to account for in the model, is that when you start looking at these different emotional behavioural needs, it's the emotional difficulties, so the anxiety, which is has the highest beta coefficient, which suggests that that's the one that's the area that's the most important in that relationship between child behaviour and parental reported psychological distress, which is really important because we know that there are lots of anxiety problems, and we know, I suppose from a more pragmatic perspective, that it's kind of easier to pay attention to externalizing difficulties because they tend to be more prominent than internalizing difficulties. But actually, it's really important that we do think about those internalizing difficulties and anxiety or emotional difficulties that some of the children might be experiencing. So parents of autistic children with learning disability experiencing more psychological distress, or reporting to experience more psychological distress than those with LD alone. But you sometimes read in the literature that it's kind of autism per se, which is associated with parental psychological distress or parental mental health problems. And that's not really how we're interpreting this here. We're interpreting this to mean that it's kind of, the autism means that there's going to be more additional behavioural and mental health things to consider. And it's the constellation of this which is linked to parental psychological distress. It's not the autism per se, which is leading, well, can't even say leading, associated with reports of more parental psychological distress. And what this means is that if we're identifying children from the age of 4 with a genetic condition, and they've got a learning difficulty, and they go on a pathway to receive an autism diagnosis, we know that, you know, there are going to be behavioural and emotional needs that are going to need to be met and thought about, but we really need that comprehensive assessment really early to help support that child, but also remembering that children operate within a family context, and that we also need to be thinking about supporting their parents and gaining some more detailed information about how best we start supporting parents within that context. If you want to find out more about everything that I've just talked about, we've published about it recently, and a quick shout out to Ramya Srinivasan, who's in the audience, who also did a great deal of work on this publication and project. Going forward, Imagine's going to be looking at developmental changes in the cohort, and we're also linking data to hospital episode statistics and the National Pupil Database. So we'll get a really rich idea of what's going on with our children and how things change over time. We do share data, so if you're interested in any of the data that we've collected as part of the Imagine study, please do get in touch with us and have a look at our website and find out and have a look basically at what's available in our catalogue. And of course, a huge thanks to our participants, our collaborators, and our broader research team who makes this work possible. Thank you.
Thank you so much, Jeanne. Lots of overlaps with Will's talk as well. So, you know, really emphasising the importance of context, particularly in the family. Again, if you have questions, write them down in the chat or on a piece of paper, and we'll get to them at the end. But our final talk isn't so much of a talk, actually. We use a talk. Jack will talk. But we asked Jack to provide a commentary on Will and Jeanne's talks. So that's what I'll just introduce Jack now. So Jack Welch is an autistic advocate who works in Dorset County Hospital. He's had several roles alongside that full-time role, including chair of MenCap's Voices Council, which is a group of experts by experience that support the governance of the organisation. And he's also a trustee of Ambitious About Autism. And I first met Jack quite a long time ago now, when he was a member of Ambitious About Autism's Youth Council. And the Youth Council commissioned us, that was me and Laura Crane when I worked at UCL Institute of Education, to look at autistic young people, 16 to 25-year-olds, mental health, including their experiences of mental health issues, but also their kind of access to services and the barriers to accessing those services. A research study that was entirely co-produced, an amazing study that we published on in 2017. So I'm hugely delighted that Jack was able to join us today and give us his thoughts on neurodiversity and mental health, but particularly Will and Jeanne's talks. Over to you, Jack.
Thank you very much for your kind words, Liz, and I'm delighted here to be, I suppose, the person who has lived experience to represent my own views and also my reflections on the two excellent presentations from my fellow speakers. I'm afraid there are no slides this occasion, so hopefully my voice alone and face will be reasonably entertaining enough. So let's try and begin on a brighter note and acknowledge that in over the 6-7 years that I have been actively involved in autism-centric research, there has been an upward trend to involve people with lived experience and a conscious effort by researchers, albeit still not fully comprehensively, to reflect the hardships which have been spoken about here. Indeed, as a PPI, which is patient and public involvement representative on the first randomized control trial, which is leading the field in assessing whether prescribed anxiety medication benefits autistic people, I was both surprised and rather heartened to know that the ethics committee at which I appeared as one of the speakers expressed fewer concerns about the capacity of participants, whether they would be able to fully understand what they were actually agreeing to. So the proposal passed without too much difficulty, and the study has progressed well with both numbers and, most important and impressive of all, retention rate and commitment for the duration required. So hopefully more autism-based random RCTs come in the future. However, as Jeanne will have pointed out, the extent of those who are autistic and have learning disability from childhood and above can be involved in research remains markedly slim. For the RCT I just highlighted and the Know Your Normal research from UCL and Ambitious About Autism and co-authored with Liz, as we've mentioned, the limitations became apparent that the views and experiences of this cohort were difficult to fully represent. In addition, the RCT was constrained by the fact that it could technically not include those with moderate to severe learning disabilities by the nature of the study scope. Now, this is important, for we know that a third of the autistic population also has a known learning disability. So the question is, are we doing too little in the broader picture to identify how interventions can meet the needs of all autistic people of different shapes and sizes? Another concern is the general direction that autism research is both addressing the needs of the population and break away from its simplistic view as another disorder which needs to be dealt with and spoken about in overly pathological terms. It has been found that research that sees autistic people only as objects rather than as partners or stakeholders is often spoken of in ableist language, and that these people such as myself are treated as other in contrast to the broader populace. So just throwing the same solutions that might work for everyone else and in the context of mental health, unsurprisingly doesn't work very well. So the question we need to ask ourselves is if we are failing to be fully inclusive, and that researchers and the funding suppliers does some of this rise from the fact that autism and learning disability are treated under the prism as mental disorders. Indeed, in my day job as in the NHS library I work in, our current classification scheme has both autism and learning disability under the mental health umbrella, with a separate additional category for the former, that being autism in pediatrics. So you get that picture that autism is still treated as a childhood condition on its own right, which it isn't. And as both speakers have identified, we have to understand the wider context we are working from and not just limit ourselves to the current model of addressing the immediate problem only. The current state of services has meant that in some local areas, autistic people might only be eligible for an official diagnosis if they are in an immediate crisis, and that leads to a reactive approach where the problems are much harder, sometimes past reasonable intervention to resolve. So speaking as someone who once sought help in the not too distant past, the autism specific option was just not palatable with a lengthy waiting list. And this is no solution that benefits the services themselves or the users and their families. And in an ideal world, we need a wraparound intensive support model of clinicians, social workers, and non-medical therapy providers as to take the holistic view and assess the situation from a bird's eye level, understanding the circumstances of the individual and not just responding to the consequences of what's already gone wrong. A shift away from the conventional medical model of treating individuals is an essential step to make it a realistic prospect. And now that we have established an overall objective of a general direction that we want to see services follow, it becomes a question of how we get there. Above all else, and perhaps beyond the scope of this response, is workforce. And until we have professionals around social work and clinical teams that are fully trained to assess the needs of autistic people and people with learning disabilities, or even there is little chance of getting this right. Both fellow speakers have also noted the shared difficulty that parents and families who experience adverse instances of poor mental health are likely to impact on those children who have been identified, diagnosed or not need. Part of the solution is developing support programs which help families of any shape and size to understand and lead happy, fulfilling lives as much as that can be possible. We know that late diagnosis has a harmful effect when it comes to the problems which will have accumulated over time, but the absence of post-diagnostic provision is the real injustice. So chances are, unless you're prepared to pay for the private clinic, which can fast-track assessment and a school of your own choosing in relation to getting an education, health and care plan, the picture in this country for now looks quite bleak, sad to say. It is not by the nature of autistic or having a learning disability, it's a disadvantage in itself, but unless you happen to have the right postcode, access and spending power for early years provision and the means to fight for the right offer of support, then the likelihood of experiencing poor mental well-being just feels that much greater. In the coming years, we are likely to see some changes on the horizon, not least of all the introduction of regular health checks for autistic people and the continuing push to have those who are wrongly in long-stay hospitals return to their local communities. But the programme of change in policy terms feels all too unambitious, to say the least. Back in 2016, Autistic's list of research priorities made the #1 selected, and this is a direct quote of using the person-first language at the time, which interventions improve mental health or reduce mental health problems in people with autism. Amongst the various strategies developed by government and the NHS on research and framing a roadmap to begin finding answers to this question, we are still building a picture of what the existing gaps are and how some of these difficulties have become so profound. Only by investment to open new research initiatives, and we know that for autism it is often substantially lower than dementia and heart disease, can we pick up the pace to bring the necessary interventions that can begin fixing this deep-rooted conundrum in our society. So I hope there might be some answers here for the audience that I've given, but as you might have gathered, resolving these questions takes a much greater and often multidisciplinary effort with the right money and the source behind it.
Wonderful. Thank you so much, Jack, especially for grounding us, you know, and then emphasizing, you know, the real challenges about including autistic people with learning disability, intellectual disability, and high support needs. And also for, you know, highlighting the real barriers to access, you know, to accessing services at present. So thank you to all the speakers for a fantastic set of talks. So now it's our audience's chance to be involved. So I'll open it up to questions now. There is already one question in the chat, which I might start with. I don't know if David, if you want to ask the question yourself or whether you'd prefer for me to read it out. I'm happy with either.
Believe it or not, I'm actually a shy American, so I'll let you read it. Thank you so much.
Yeah, of course. I won't read all of David's question out, but the question is around an opinion that it was put forth by one particular researcher, but is I guess one charge made against the kind of neurodiversity paradigm, and that is that it is grossly unrepresentative of more impaired people, particularly when viewed through a mental health lens. And David asks, what can we as researchers do to address this and be part of sustained solutions? So I'm going to put that to Will, Jeanne, and Jack to see what their thoughts are.
Thanks, Liz, and thanks, David, for a really, really interesting question. And I have to confess, I haven't actually read that paper by Jeanne Russell, so I will. Thanks for alerting me to it. I'll read it after this. But thinking of the general question, I mean, there's a couple of thoughts I have on it. I think, you know, as you say, Liz, it's a common thing that people raise when one talks about the neurodiversity movement. But I sort of feel like, you know, if we think about some of the fundamentals of that, you know, for example, as set out by Liz and Jackie Den Houting in that paper, I think they still really do apply. So, you know, if you think about, you know, fundamentally what is the aim here of, you know, of autism practice, I still think it's perfectly valid for somebody who maybe does have, you know, an intellectual disability, might be minimally verbal in addition to being autistic, that really what you're trying to do is to maximize their well-being and their kind of you know, quality of life. You know, that seems to me still, you know, with whatever group, a legitimate ultimate aim. It also seems to me legitimate that is part of how you think about that and how you do it isn't just going to be thinking about the person and their, you know, individual characteristics, but it will be hugely influential their environment. And in fact, you know, people working clinically, you know, that's very often, isn't it, the work that you're doing in these settings is actually tweaking the environment and fundamentally working to improve person-environment fit. I think the bit that is undeniably challenging, and I've definitely been guilty of this myself, is that it's effectively, you know, to put it simply, it's easier to listen to and relate to people who are verbally fluent than people who aren't. You know, that's just the reality. And I think so. I think there is something about, you know, we as researchers, we've got to put the work in. Essentially, you know, it really takes work and thought. It involves going a bit slower. You know, in your work, you might need to invest more time in the consultation process. And yeah, I mean, so and I do think that is probably one of the things that Ginny might be getting at, is that I think there always is a risk, isn't there, that people literally with a voice could end up with a disproportionate influence compared to people who aren't able to communicate in the more kind of, you know, quick and conventional forms. So yeah, I do acknowledge that as a challenge that we've got to keep working to overcome.
Thank you, Will. Thank you.
Jeanne or Jacques, do you want to comment or answer the question?
Yes, I suppose coming from a lay perspective, so it's not, it's again someone who hasn't fully read the paper, just to also disclose that. But I know there has been some similar debate quite recently around autism in general about whether we should use terms like profound autism to distinguish from, you know, certain classifications of, you know, autistic people, and how severe the condition might be affecting their life and well-being. So, you know, I'm one of those who are inclined to say that autism as an umbrella is sufficient in its own right, and the problem of excessive labelling of people, and again, potentially pathologizing, you know, using medical model language and terminology is often quite harmful in many respects, or, you know, undermining, you know, the individual themselves and their capabilities. So let's say someone who's autistic and non-speaking, it doesn't mean that person doesn't understand what you might actually be saying, and indeed that includes not just non-speaking, but those who are selectively mute as well, because that is something in its own right. So I suppose I do take some general issue that, you know, within taking regard to the mental health lens, I think it is somewhat misleading, and I think we need to, you know, make sure that we stay on the path of distinguishing people who are neurodivergent and those who generally have a disabling mental health condition, which you know, causes difficulty with their general well-being, if that be on it. That there is still hope and possibility to provide support and enablement for people of all needs, and it's trying to adapt around that individual's personal needs. So it's a challenge for all of us, but I think it's trying to build that inclusive environment is the main goal and objective here.
I completely agree with Jack and Will, and I'm not going to speak long to this so we can get through other questions, but I think what's interesting is how this debate plays out in adjacent fields. So how, for example, in the world of ADHD, they're talking about the neurodiversity framework of Wolstencroft. It's quite interesting because it's the same issues but with a slight different flavour to them.
Yeah, thank you, everyone.
Thank you.
Thank you, David, for the question. I can't see anyone with their hand up, I don't think. So I'll move on to Sarah, who has a question in the chat as well. Sarah's a parent. I'm okay reading this, Sarah, on your behalf, unless you want to pipe up, and you're more than happy to read it yourself. I'll go ahead. Are there any organisations in the UK that help autistic children with anxiety and emotionally based school avoidance? Sarah says, we haven't had much help from CAMS. Also interested to hear about any support in places for parents, especially as we're in the more challenging category of parenting an autistic child with a learning disability.
Yeah, I suppose I preface this with, I think there'll be people on this call who'll know better than me, you know, because I'm not working, you know, clinically in the NHS at the moment and so on. But I'll just, you know, so please do chip in if you have other thoughts. But I suppose, yeah, I mean, obviously, you know, CAMS would be an obvious place, and it clearly sounds like you've tried that. I suppose I'm a bit curious about what school are doing, and whether there are resources, you know, in the school system, you know, through the Senko or, you know, or local educational authorities, educational psychology stuff. And again, in terms of support for parents, you know, which I think has, you know, been a really important theme today, hasn't it, of the need to support the whole system. I suppose again, one thought I have is whether you're engaged with a local learning disability service, and whether there's any kind of, you know, because there often are quite systemic approaches they take there. I mean, I suppose another thing is IAPT, you know, so this is this primary care, improving access to psychological therapies, that, you know, you should have locally, you know, where that's kind of their bread and butter is working with, for example, like anxiety and depression and things like that. So yeah, sorry if that's probably not particularly helpful, but those are my thoughts on where you might look.
Yeah, I'm thinking, to echo what Will's saying, sometimes the support doesn't come from the most obvious charities, and you know, if within kind of like the Autism Charity Network there seem to be no resources, looking to the Learning Disability one or the Carer Forum type places often have resources, and I'm thinking particularly of Cerebra, who's a charity who looks at challenging behaviour predominantly, but they've got lots of fantastic guides on when experiencing barriers to accessing services.
And I'd probably recommend contacting an organisation like Contact as well. That's the name of the charity, because they are specialists around, or their helpline is anyway, that they are specialised around disabled children in general. So they will, you know, be able to provide certain responses, services that might be available.
Thank you, everyone. I hope that helps a little bit, Sarah. Thank you also for highlighting emotionally based school avoidance. I know there's that's a real issue, particularly post-COVID, and there isn't, I know because I've just written a manuscript on this, that there's very, very little research on it. So yeah, so to all the researchers out there, we move more research on school avoidance issues. Is there another question?
People want us to get out, want to get out into the sun, obviously.
I think so.
We can wrap it up early, Liz, if there are no more questions and people are yearning to catch the sun for a bit.
One more question, anybody? Hang on. There's a lovely comment. You're all amazing. We might take that and leave now, just in case we say something wrong in response to the next question.
Quit while we're ahead, yeah.
Yeah, exactly. Thank you all so much for a wonderful session. Fantastic talks from each of our speakers. Really, really good questions. Yeah, thank you so much. So this is the final a Catalyst seminar of the series, and they will commence again in the autumn, so October. So please look out for an email, probably yeah, in your inbox, well, closer to October, I assume, once we know the schedule. But go and enjoy the gorgeous day that is ahead of us. Thank you so much.